So you all semua dah ada dah? Are you all dah ada 7 orang ni?
Ada one student.
Ni apa? Oh, dia tak dapat hadir. Dia present tak? Dia present?
Ada yang share device, Salwa dengan Aina. Semua ada dah.
Semua ada. Yang kata ada seorang tak datang tu?
Kalau tak, dia orang share device.
Ya. Ada seorang ada appointment.
Oh, ya ke?
Oh, Syakira.
Ada tak? Semua ada dah? Ke tak?
Ada seorang,
Ha?
Syakira dia tak dapat datang. Appointment.
Dia present tak?
Dia tak present.
Tak present. Tapi rugilah dia sebab ni kadang masuk exam.
Oh,
Dia appointment apa? Appointment apa dia? Tak tahu. Okey, siapa dulu?
Saya
Oh, okey ha. Berapa orang presenter?
presenter ada 4.
4 orang. Jangan tulis yang. Ibrahim Zaki Okey.
Assalamualaikum warahmatullahi wabarakatuh. My name is Ibrahim Zaki. Today I will talk about ECG. So what is ECG? ECG stands for electrocardiogram. It is the recording of the electrical activity generated by the heart. So the device used to record the electrical activity, we call it as electrocardiograph. And the procedure itself is electrocardiography. The standard type of ECG used is 12 lead ECG, which it has limb leads and precordial leads. Limb leads, it has 2 types, standard and augmented. Standard limb is where the one lead is positive and another lead is negative. For example, in L1, left arm is positive and right arm is negative. For augmented limb, the lead, one lead is positive, but all other leads are negative. For example, in LVL, left arm is positive, other limb leads are negative. For precordial leads, we have 6, which are V1, V2 shows the right ventricle, V3, V4 septal, V5, V6 shows the left ventricle. So
AVL bisa balik semula.
AVL.
Standard limb will be limb kan?
Limb lead.
Dia punya dia. Okay.
So for the indications of ECG, syncope, seizures, and funny turns. Funny turns meaning that the patient is dizzy and require to lean on wall for stability. Another indication is cyanotic episodes, chest pain or other symptoms related to exertion, drug injection such as amphetamine, which is used as street drug. The diagnosis and management of heart disorder such as rheumatic fever, Kawasaki's disease, pericarditis, myocarditis, abnormal rhythm of the heart, congenital heart disease, and also if the patient has family history of sudden death or when the patient is in a life-threatening event. And lastly is electrolyte abnormalities such as hypokalemia, hyperkalemia. ECG is a safe procedure where it is non-invasive test. So it has only few side effects such as mild rash or skin irritation and also allergic reactions. The side effects usually is due to because of the gel and also the electrode. The list of equipments in ECG are the ECG machine itself, electrodes, ECG paper, and skin preparation equipment such as hair removal device and also cleaning wipes to remove the gel when it is used. So the gel used is actually to improve the conductivity between the skin and the heart rate monitor electrode. So the process of electrocardiography is first the patient has to remove any jewelry on his or her body, and also the patient required to avoid any skin cream or oil before the procedure. Next, the patient should remove their clothing and also their socks if they wear any.
Ini adult kan?
Adult. Tapi
Kenapa tak bersih pediatrik punya? Pediatrik tak payah duduk apa, pediatrik dia boleh baring tau.
Sebab saya refer dekat ada guideline daripada kat Australia. Dia gabung pediatrik dengan adult.
Ya, okeylah ha. Tapi yang adult small children, pediatric small children, kita lie on the bed dia. No, small children, 2-3 years old. Kita tak supine. The baby, kita tak supine macam mana? Continue.
Electrode placement. Next is lead wires to attach to the electrodes. And then before we start the ECG, we have to key in the patient information such as the patient's name, age, and also the hospital number. And after that, we disconnect the leads and remove the electrode. So in standard ECG, the paper speed is 25 mm per second and one small square. The length is 1 mm. For the horizontal, it used to measure the duration. For example, in one small square is equal to 0.04 second. And for vertical, it measures the amplitude, which one small square is equal to 0.1 millivolt. So for the precordial leads placement, V1 we place it in the fourth intercostal space near the right sternum. V2 at fourth intercostal space near the left sternum. V3 is between V2, V4. V4 is located at the fifth intercostal space but at the mid-axillary line. V5 same level as V4 but we put it at the anterior axillary line, and V6 we put at the mid-axillary line. Sometimes the lead has the electrode has color, so which make us easy to place the electrode. We can simply memorize this as traffic chocolate, blueberry. V1 is red, V2 is yellow, V3 is green, V4 chocolate, and the lead is blue and violet. And for the limb lead, we put it more proximal location because to reduce movement artifacts. We can also memorize the colors to make the placement easier, such as traffic light black. Red, right arm, left yellow, left leg green, and right arm black. For children under 5-year age group, we put alternate lead V4R, which has the same level as V4. This is because their right ventricle is located near the right sternum. Okay, let us proceed with video.
This is Ella Rose, and today we are performing an ECG. I have already
Oh, tak
gained
nampak.
consent.
Saya tak nampak. Okay. Boleh proceed. Proceed lah. Kenapa tak jalan?
Tak ada suara
Tadi ada, tapi tadi masih ada suara, tak nampak tu.
Now we're just going to take the ISO wipes and we're going to wipe over the areas that we exfoliated.
It smells like the glass is washed.
Yeah, it does, doesn't it? It's got alcohol. There we go. So now we're ready to place the electrodes onto Ella Rose.
Yeah, we've tried them
Yeah,
before.
tried them before. So I'm just going to feel your ribs again. The electrodes are placed on the body facing down. Just feeling Ella Rose's spaces.
Can I take them off?
Yeah, when we're finished you can take them off. Yeah?
Yeah.
Good. So this one is coming where? So on the child we place one of the electrodes over to the right side of the chest. And then one comes under your underarm. Just under here. How's that?
One more.
Electrodes on the wrist will then be placed facing down. And one on the other one.
Yang LV4 tu dah right side nampak tu kan?
And ankles facing up. It's a bit chilly in this room.
Kat Malaysia ni kadang even 6 years, 7 years pun boleh letak juga because the body size small
I didn't want to do this.
But usually standard less than 5 years old.
You're going to be like a movie star now.
You are going to be like a movie star. Now we're going to attach the wires onto the electrodes. No. I've got the numbers on them.
Go. Just stay there.
Okay, so let's go. So we just attach them to the edge of the electrode, making sure the clip doesn't go too far up onto the electrode. And comes after 3. 4.
5, 6, 7, 8, 9, 10, 11, 12, 13, 14.
You're so good. How old are you?
6.
6? You look too little for 6. You look about 5. Just try to keep the wires straight without too many kinks in them. When is your birthday?
I forgot. August.
What number?
20th.
20th. Ooh, that's exciting.
It feels funny.
It feels funny. So Ella Rose, in a minute, I'm going to get you to lay. So now we have all the electrodes on. We're going to instruct the patient to lay nice and still. No talking or moving for a moment. I'm going to cover you up now, sweetie. And we just cover her up to maintain her dignity. And I'm going to come over here and take the picture. When she's laying nice and still, we have a nice clear trace, nice steady heartbeat, we're going to start. No, there's not letters inside your body. Now we've got the trace. Well done. Just unclip. We unclip the wires from the electrodes. Pull the electrode off, stick them to the glove on the back of the hand. Good girl. This one. Put it on here. Just going to fold that back. Good girl. And then we're going to just peel them off. Ooh, that one's a little sticky, isn't it?
Ow.
Ouch, lucky you're not hairy.
Ouch.
Ouch. Ouch.
Last
Last
one.
one. Good girl. And we're going to slide them out of there. Good girl.
That's all from me. Thank you.
Okay. Okay, I hope you all learn. Any questions? Itu yang budak tadi ada tak dia supine tu? Sit up position, tak ada kan? In children, because in children, the most important is the patient must be comfortable. If not, they're not cooperative. Yeah? And then you see the most important how they communicate to the child you see you have some sense of communication with children to make them become compliant or cooperative with you. Notice that macam mana dia communicate dengan child tu. Very nice, is it? Then this is a part of training. And then I think that's all. About the interpretation, you have to read yourself. And then because interpretation or ECG is another complicated topic lah. At the moment you will know how to do it is good enough already. Okay, next. Next speaker. Siapa? Aina Madiah.
Yes.
Okay.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. My name is Aina Maria binti Hisham, entry number 1716762. So I'll continue with bone marrow aspiration and refined biopsy. So here is my table of contents. So I'll start with intro and lastly methodology and followed by video. For the introduction, bone marrow aspiration is a procedure that removes a sample of liquid portion from the bone marrow. And another one, which is refined biopsy, is to remove a small solid piece of bone marrow. And it can be done by palpation or CT guided, which both have high accuracy and low complication rate. And it can also be done whether inpatient or outpatient. And the most common site to do the aspiration biopsy is at the posterior superior iliac crest, either in adult or in children. So for indication, it is for to diagnose hematologic disorder like leukemia, multiple myeloma, lymphoma, unexplained anemia, and myelodysplastic syndrome, as well as aneuploidy in infants and fever of unknown origin. And lastly, for atypical fungal and parasitic disease like histoplasmosis, leishmaniasis, cryptococcus, and also Q fever. So for contraindication, before I talk about the contraindication, for patient with bony resorption, due to metabolic or lytic process like multiple myeloma, we should aspirate at iliac crest, not sternum. Because if we aspirate at sternum, there is risk of perforating the sternum and also towards the mediastinum. And also thrombocytopenia is not a contraindication because we can just transfuse platelet if we want to do bone marrow aspiration.
But
Or
usually
the-
if platelet is more than 60,000, we don't need to transfuse. 50,000, 60,000. But then for the dose below than that, we transfuse platelet first. Okay. Continue.
And then for absolute contraindication, if the patient have severe bleeding diseases like severe hemophilia or severe disseminated intravascular coagulopathy, DIC, and they do not indicated for bone marrow aspiration and refined biopsy. And other additional contraindication include biopsy at sternum. So we should avoid biopsy at sternum to avoid perforating the mediastinum. So for the complication from bone marrow aspiration and refined biopsy, firstly is post-operative bleeding due to high vascularity, and also to avoid this bleeding, we can do manual pressure or pressure dressing at the area. And then there is also risk of retroperitoneal or gluteal hemorrhage, which is rare. It can occur when there is injury to internal iliac artery or superior gluteal artery. And also, the most severe complication is when there is cardiac tamponade and also death when we misplace a needle during sternal aspiration. And another one, as we know that bone marrow aspiration is an invasive procedure, so there's risk of infection, and we can minimize the risk by proper sterile technique. And for patient with tumor, there is also risk for tumor seeding, especially at the site of suspected metastatic lesion. So we should always advise the patient of this risk, and also damage to local tissue, especially for non-cooperative or combative patient. So we need to always sedate the patient to avoid this thing to happen. And then for the list of equipment, firstly, we have bone marrow kit, which includes sterile drapes to avoid the risk of infection, and needle, syringe, and also aspiration needle, like in this picture. The syringe, needle, biopsy needle, and aspiration needle. Also, biopsy needle, we always opt for Jamshidi needle if we do the bone marrow aspiration at the posterior class. So this is the Jamshidi needle. We have the centimeter guide here. Next, for sedation, we can prepare 1% to 2% lidocaine with or without epinephrine, and also other things like specimen slide and specimen containers to keep the specimen that we take from the aspiration and also biopsy. And here is the amount the biopsy kit content, which include the specimen tube and also slide, specimen, and other things. So for the methodology, firstly, we should identify the landmark. So for the most common site for bone marrow aspiration is at the posterior superior iliac spine, which is at the back of the hip. So we can identify it whether by CT
In
guided.
children, we also do on the tibia, anterior tibia. Small children, we don't do only in the iliac fossa. We also do in the we don't do on the iliac bone only, but we also do on the anterior tibia in children. This the proximal anterior tibia. Okay, continue.
Next, we should also do the PPE and organize the tray and equipments and anesthetize the patient using the lidocaine. Next, we should do a small incision at the area for skin entry and select the appropriate bone needle size. And then we scan the for proper, when we have insert the needle, we should scan for proper angle to make sure the angulation has been achieved, proper angulation has been achieved. And then when it is confirmed that the angulation is proper, we should advance the needle into the bone while maintaining the gentle forward pressure towards the bone marrow cavity, and after that we can remove the stylet. And then for the first one, we do aspiration, so we take the aspirates, which is about 2 millimeter from the syringe. And then here is among the steps. After we have done remove the stylet, we rotate and so on. We can take the aspirate and put at the specimen slide. So this part is for aspiration. Next, for biopsy, we can insert a biopsy needle to the same area, same site, and puncture the site. And the area is by clockwise and counterclockwise. And we pull the needle gently to get the biopsy sample, which is the bone marrow.
We suck, this one. Usually we put a big syringe and we suck, suck out the barrel content. Usually, if you find different, we don't suck out. Continue.
So after we obtain all the specimen, we can do the smear at the slide or put the biopsy sample at the container. And that's
In,
for
in, in define, biopsy marrow, bone marrow biopsy to take marrow, define is we take the bone, No, define we take the bone. We don't suck up, we just take out quickly, so we get the bone sample, And then define, we look into the example, aplastic pneumonia, So we can look for the content of the inside the bone marrow if there any replacement or not by other tissue. Okay, continue.
okay, here is for the video. Video for the bone marrow expression in children.
During the consolidation period of chemotherapy, an individual may receive a bone marrow aspirate or biopsy. Many people get these two things confused. The main difference is, with a bone marrow aspirate, the goal is to retrieve the liquid form of bone marrow, and bone marrow only. This is retrieved from the center of one of the major marrow-producing bones, almost always the hip. In a bone marrow biopsy, the main purpose is to retrieve an actual solid piece of the bone. Today, Austin's procedure is a bone marrow aspirate. The purpose for this is to collect data that will explain how well the treatments are working for Austin. The liquid marrow will be analyzed, and a pathologist will be specifically looking for the APML genetic abnormality in the leukocyte cells. The big question: how many remain? Hopefully the response will be none at all. This is Austin's third bone marrow aspirate. He receives anesthesia for this procedure, as is protocol for all children under a certain age. I'm not sure what the cutoff is, but at some point people are not put out for this procedure, but rather are awake, while a needle is inserted into the bone and in a drill-like fashion plunged into the center of that bone. While speaking with one of my dear friends currently in his third year battling cancer, he has undergone more than a half dozen bone marrow aspirates, all awake. As he tried to explain the pain to me, he just started to cry.
I'm sorry, Daddy.
You do whatever it takes. I'm just so glad that Austin does not have to be awake for the procedure.
Ken's got the 2 So, I just pull my 5 cc's and then you put in there, or is it a different tube?
It's a pearl one, and Ken will put it in that one. So you draw it out and you squirt it in 3 to 5 cc's.
Oh, okay.
Yeah, so the
Does that have speakers?
yes, it does. Good speakers.
Okay.
Good.
Just to show you
It's called Be Patient with Yourself,
how
right?
subtle this can be.
Right, and that's
Just looks best.
Yeah, so if you just lower the
this one.
The population range is actually
A word of wisdom to all saints who remember to walk in obedience to these commandments shall receive health in their navel and marrow to their bones, and shall find wisdom and great treasures of knowledge, even hidden treasures, and shall run and not be weary, and shall walk and not faint. Never before have I understood the importance of healthy marrow like I do now, and how it is life's true wealth to be able to run and not be weary, and walk and not faint. It is my prayer that Austin will have these blessings and enjoy them for a long cancer-free life.
Do you like Doritos or Cheetos? This one?
That one for Ashton.
So I think it's for for pulmonary respiration and Y5B1.
Wah, yang ambil yang ada lagu punya lagu dia more of the apa tu, the ni, not technical tapi more of the apa tu, information for the general public. Because the technical, I mean, you have to show step by step how you do it. Okay, anything else? Any questions? Okay, next. Next presenter.
Assalamualaikum. My name is Musara Chaira binti Muhammad Fuad. So today I will present about CPR in children.
No Salwanya. No Salwa. Share. CPR, okay.
Okay, for introduction, so CPR stands for cardiopulmonary resuscitation, and it is a life-saving procedure that involves rescue breathing and also chest compression. And today I will talk about CPR in a child. So a child here means 1 year of age to the start of puberty, and it can be evidenced by presence of axillary hair in males and breast development in females. For the indication for CPR, first is cardiac arrest when the patient is pulseless, and also bradycardia when the heart rate less than 60 per minute with poor perfusion. And then for the complication that may arise if there is the CPR not be done appropriately, so it may cause rib and sternal fractures, and then pneumothorax, hemothorax, pulmonary contusion, aspiration, and also have the risk to transmit infection. Okay, for the
pulmonary contusion lagi, aspiration. Okay.
For the equipment, so if the rescuer should wear PPE such as glove, apron, and mask if available. And then for back mask device, it is usually be used in a hospital setting because usually the ventilation is given through the back mask device because it can prevent the risk for disease transmission. And then we also need the AED, automated external defibrillator, to determine if the rhythm is able to shock or non-shockable. In situation, if the patient is suspected or confirmed with COVID-19, so the CPR provider should wear appropriate PPE when enter the patient room, and should limit the personnel who are performing the CPR, and should provide the rescue breathing using a back mask device with a high efficiency particulate air HEPA filter, and ensure there is a tight mask seal. Okay, so for the method, so I will discuss a bit before doing the CPR. So first need to look for danger, make sure it is safe to help, and then we need to check for the patient, for the child responsiveness, and we may tap the child's shoulder and say, "Are you all right?" And then we shout for help. If there is if in hospital setting, we may say emergency, so bring the resuscitation trolley and also the defibrillator. If it is outside, so outside the hospital setting, so we may need to ask help from other people to call 999 and ask them to bring the defibrillator. And then we look at the airway, so we need to open the airway and to
Kita 119 je.
No, 999.
Kita 199 ke?
Kita
Ya?
999.
999 kan?
Okay. After we open the airway and then we look for bleeding. So we should we look for normal bleeding, not more than 10 seconds. And then we see if there is no bleeding or if there is abnormal bleeding. So we need to give the initial 5 rescue breath. And then we go to the circulation and then we check pulse. Actually, the pulse and the look for the bleeding and pulse can do simultaneously, and it must be within 10 seconds. And then if for children, usually we can feel the carotid pulse, and if not, we can also feel at the femoral pulse. And then if we within 10 minutes, we still do not appreciate the definite pulse, and then we can start the chest compression. And then the chest compression, according to a new guideline by American Heart Association, it said that the compression need to be 30 compression to 2 ventilation, and each ventilation should be in 1 second. And then after that, when the defibrillation is available, so we can assess whether the patient need to be shocked or not. Okay, this is a little bit about the chest compression. So it should be performed over the lower half of the sternum with either the heel of one hand or with heel of 2 hands. Okay, and the effectiveness of the chest compression, first, the chest should be depressed at least 1/3 of its anterior posterior diameter. With each compression, the depth about for child about 5 centimeter or 2 inch, and the optimum rate for the compression approximately 100 to 120 per minute. And each compression, we must make sure that the chest should fully recoil, and then we should ensure there is minimal interruption, and we need to perform chest compression on a firm surface. This is my reference. This is the video.
Today we're going to review BLS for the healthcare provider for the pediatric patient, for the child. Let's take a look at those skill steps now. First, establish unresponsiveness. Next, look for breathing for about 5 seconds. If this child is not breathing, immediately call a code, get some help coming. Now, in healthcare provider, 2 rescuer BLS for the child, our compression to ventilation ratio is 15:2. You're going to provide 15 compressions, then provide 2 ventilations of air. We're still going to attach this child to an AED to see maybe if they are in a shockable rhythm. Let's take a look and see what those skills look like, shall we? Hey kid, you okay? This kid's unresponsive. He's not breathing. Nurse, call a code. Hey, this kid doesn't have a pulse. Hey, get over here with that AED. I'm starting compressions. And go right to 15:2.
Place electrodes.
The AED's here.
Place electrodes.
Hands on him.
Place electrodes. Do not touch patient. Analyzing rhythm. Do not touch patient. Analyzing rhythm. Check pulse. If no pulse, give CPR.
This kid's got no pulse.
That's all from me. Thank you.
Okay, that one is basic life support. Jadi lagi advance basic life support. Dia basic life support. Advance, you kena tahu pula what medication to give. How to give, when to give. When to give adrenaline. When to give the, if you need to give anti muscle relaxant. Mainly adrenaline lah. When to give adrenaline, oxygens. Then there is the other things you need to learn. Okay, any questions? Even fluid also you must know, or at least you have to understand when to give the fluid, what type of fluid to be given during resuscitation. Okay. Any questions? Okay, next presenter.
Yes, can you guys see my slide?
Yes.
Is it? Okay, Assalamualaikum. So I will present about CPR in infant. So just to note that most of the points have been mentioned by the presenter before, so I will just go through briefly. So it's CPR, chest compression with artificial ventilation to preserve brain function. So usually we do in patient of cardiac arrest. So infant, the most important point here is infant. Infant is children who is less than 1 years old, including neonates, which is less than 30 days of age. Okay, so indication, respiratory arrest. So in infant, the most cardiorespiratory arrest. So in infant, respiratory insufficiency is more than the primary cardiac problem. Then bradycardia, which is heart rate less than 60 minutes, with pulse and poor perfusion. For contraindication, basically, the absolute contraindication for CPR is there is a DNR order, do not resuscitate order, or if in cases of institution where the procedure is medically futile, where the patient have no chance of survival. Okay, next, so just to mention about the chain of survival. So CPR is one of the in the chain of survival is the second step, which is the chain is for survival is very vitally linked for better survival of patient. So in CPR also in cases of pretty trained bystander or medical personnel, so we give CPR and ventilation. In cases of the bystander is not well trained, so CPR alone is enough. Okay, so for equipment in CPR, so basically we can equip by back valve mask. So this is in case of in hospital setting, and then also AED. Also the same in case of hospital setting. If outside hospital, we don't need any equipment. Next, so this is the step by step. So the same, we use the mnemonic doctors ABCD. So first, we look for danger. Make sure that surrounding environment is safe, no electric wires, no blood spill or any sharp object. Then we check for the responsiveness of the child. So we gently stimulate and try to awake the child, then check the response. Then next, as we shout for help. So if you are alone, so we can immediately start the CPR. And if there's somebody around, we point at the person to call 999 and bring the defibrillator AED. And then next, we will perform the airway. So perform head tip chin lift. So in infant, mainly noted that because of the difference in anatomy, so we don't overextend the head tip chin lift because it will definitely block the airway. So we just put the infant in the neutral position and slightly perform the head tip chin lift. And then if there's a suspected of spinal fracture, so we do the jaw thrust. And then we look for reading, not more than 10 seconds. And so if there's no reading, we immediately give 5 rescue breath. And then after that, we start the chest compression for the C circulation. So during that, so in infant, the most important thing differentiate is the technique that we use. So in infant, we use the 2-finger technique. Basically, we use our middle finger and our pointing finger. So we put our fingers at the nipple line at the sternum, at the level of nipple line, and then we start the chest compression. And then also we can use the encircling technique, which is we put our thumb and then we encircle the infant body, put the two of our thumb at the same level, the nipple line level, and then we start the compression. So this encircling technique is evident they are better than the two fingers technique. So this we can use this technique when there's 2 person. So another person will manage the ventilation, and the another person, the other one will focus on the compression. So for this guideline, I take from the Ministry of Health guideline. So they suggest that 15 compression to 2 ventilation. So with each ventilation, we give for 1 second. And then lastly, we assess for any need for shock by ED. Then if the CPR is successful, so we can put the children in recovery position. So and then supporting the children, the infant back by placing towel or blanket or pillow to support the child in recovery position. So for high quality CPR, so the compression must be 100 to 120, and then the depth is 1/3 of the chest, or mainly about 4 to 5 cm. And then there must be minimum interruption in chest compression less than 10 seconds. And then for every compression, we must allow full spontaneous recoil. So in case of CPR, we must continue until the child is have obvious sign of life, or AED is ready to use, or there's another one to help us to take over the compression, or another person arrive that are more better than us, and or we are alone and then we are too tired to continue, or the scene become unsafe, or we have perform, or in case we are alone and then we are perform the 2-minute CPR with 5 cycle, and then we need to call the emergency number so we can stop the CPR. So this is
just now the compression is 15.2 ke 32?
in the guideline 15.2
for infant.
For infant.
Adult tadi 32
adult 32.
Okay, adult pediatric.
Pediatric.
Okay, continue ke depan balik. Okay. Then
So
after that, when you start CPR biasa, after initial one will be 32, is it? Is it?
32
is initial only kan?
Initial.
Continue Pardon?
Or in the one guideline I 32 is when we are alone.
Okay. Tak dengar?
Tak dengar.
Are you okay?
Okay.
No response, call 911 immediately.
Call 911.
If the infant is lying on their stomach, turn them onto their back. They should be lying on a hard, flat surface. Check for breathing and signs of life. Watch their chest for any normal movement. Look for signs of life and breathing for no more than 10 seconds. No breathing or signs of life, begin CPR. Position 2 or 3 fingers on the center of the infant's breastbone, just below the nipple line. Compress the chest 1.5 inches in depth 30 times.
1 and 2 and 3, 4 and 5, 8, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30.
After giving compressions, give breaths. Tilt the infant's head back slightly, using one hand on the forehead and lifting up on the infant's chin with 2 fingers with the other hand. Cover both the infant's nose and mouth with your mouth. Give 2 small, slow breaths, watching for the infant's chest to rise. Continue with 30 compressions, 2 breaths. Continue CPR until you see signs of life, another rescuer takes over, or help arrives.
Okay, that's all from me. Thank you.
Any question tak?
Doctor, I would like to ask one question for CPR in children, because before this, the guideline said that the compression is 15 2, but now 32. So why they change it?
Don't worry, another 2 years they change balik. They keep on changing. This edition 10, 12, 13, 14, 15. Kita orang pun tak tahu dah. They keep on changing. I think that's why they have new edition. You tahu nanti with the new edition dia tukar balik. So I don't know, because I think it based on the new study, newer study, which is the better outcome, and then simulation. I think by computer simulation and so on. But most of the time we really don't know. But because we're using them as a technicality, that's why we follow. Actually, sometimes I don't know. I have no comment about that. So easy standardized. Somebody use 15, and one use 20, and the one use 30, and then as a result, until we do CPR, we cannot synchronize. So we use one center, which we follow one place. So the whole team was trained in such a way, same technique. And then if you have team for different place, you just meet once, everybody know what to do. That's why we just follow. Okay, anything else? Okay, no more. Okay, finish.
Doctor, I have a question regarding the seminar. So if you are not available on Friday,
we may do on. We will probably on Thursday next week. Thursday next week probably, but we do in the. For this seminar, I would like to do face to face. Nanti I will tell you where. Kuliah, kuliah medicine probably 4 o'clock, something like that, 4:30. For roughly 4:30.
Okay.
Kuliah medicine, because you cannot use SASMED because you all from few of you from HTA and mixed group so usually for this seminar teaching, whole of you have to be around, and then we may do it on Wednesday 4:30 at Com is
Wednesday or Friday? Wednesday or Thursday?
The other Wednesday next week.
Okay.
Next Wednesday, that one will be on.
But I think that is procedure presentation
for certain group.
For certain group.
If not, Thursday lah. Thursday 4:30.
Okay. Okay, doctor.
You tell them for Thursday 4:30 at Com. So Thursday. This one, we call it problem-based seminar. It's not seminar per se, it's problem-based seminar. So your problem is autism. How to. Okay, anything else? Okay, so we do 4:30 at Thursday. At kuliah. You ada problem tak access the kuliah hall?
I think we need to book first to
book
see
lah.
if there's any available.
Book lah. Actually, people not using the kuliah anymore as much as before, because of the like this one, your case-based study, case-based seminar, and then your CBS case-based seminar, and then your procedure seminar, all will be in online, is it? So that's why it's not much conflict anymore. So unlike before, where most of the teaching will be face to face, but this time probably 40%, 50% your teaching will be online, except for bedside teaching. The rest will be on seminar online, and then but the problem-based seminar like autism, it depends to the lecturer. Some lecturer probably allowed to do online, but some lecturer like to do it in the face-to-face. So you have to ask the lecturer, there's lecturer how they want to do it. So for problem-based seminar, I would like to do face-to-face. So we do on Thursday. But the other lecturer, perhaps they don't mind to do it online. So the rest will be like case-based seminar, and your problem that the procedure seminar will be online, like what you are doing now. And then the basic teaching only is face-to-face. And then how is it your bedside teaching? Your bedside teaching, you have any problem or not? No,
No. Okay.
You have your bedside teaching HTA, any problem?
No.
No, do you have any problem to go to HTA? HTA, any problem or not? Did you tell you all how to arrange yourself in such a way so that you all didn't come at one time, so didn't crowd the what? Did they say? Did they advise you?
Yes.
They let you to arrange yourself, or do you they arrange it for you?
We actually have the timetable arranged for the morning and evening shift.
Okay.
And also for the nurse, the staff there, they have separated us into cubicle. So 2 each for each cubicle.
Okay.
In the ward.
Please follow. And I don't know how Omicron will change. We expected Omicron will land here in middle of January. In middle of January, Omicron will land here. We really don't. Now we have Omicron already, but is under control, because mostly it's come from they detected those who are visitors from the but then we believe that matter of time, in a matter of time, it will be replaced Delta in Malaysia, and Omicron will be, and then there's a new variant which is quite, the mutation is quite extensive, 30 mutation. So we really not sure how it's going to affect us in long run, in when we had it, because if you look at the UK, US, everybody has start to clamp down. US, UK, Europe, everybody start to clamp the down. The interactions and the social interaction. So we really not sure how Omicron will affect the teaching overall, and because it will start with the patient first. So there may be some changes when Omicron come, but until further notice, we continue as such. And then please, you all, one, behave yourself properly there, and second is make sure not you the one who spread the Omicron. because the effect on us in terms of teaching wise will be quite great if you got the blame, if you got the blame. So if you unwell, if you got symptoms, please don't go, because if you kata kebal terpalik sekor, lumpur semua akan kena, tahu. Susu tu setitik rosak nila setitik rosak susu sebelanga. So please be aware of that. Okay, anything else?
We have this morning we have a session with Prof. With Dr. Alwi. So after the BST, we have 2 questions lah yang Dr. Alwi suruh we find out from you. So tanya in case of pneumonia, so do the breath sound increase or reduce?
Breath sound, pneumonia, breath sound, if it's lobar pneumonia, breath sound will be increased.
Lobar pneumonia.
Tapi breath sound, the vocal but ANT will be reduced. All pneumonia ANT will reduce. Remember that. But the vocal frequencies, there's no such a breath sound. I don't know who start the breath sound. There's no physical examination finding breath sound. Is AN3 is reduced or not reduced? That's all. There's no breath sound. And then second thing is that the vocal frequencies or vocal resonance, that one can be increased. And then on percussion, there will be dullness. So there is AN3. There's no breath sound. There's no medical term in examination breath sound. Okay. Anything else?
Then second question, so in bronchitis, so on percussion, do we hear resonance or dull?
Bronchitis, nothing.
Nothing.
Because bronchitis is the bronchiole, not the parenchyma. Most of the time, the auscultation can be some reduced or not much you heard, or anything can be good. The bronchitis, the main symptom will be cough. You will cough, and then you don't hurt much the other signs. But percussion can be normal. Most of the time it's normal in bronchitis. Okay, anything else?
Okay, thank you, Doctor.
Doctor, how about bronchiolitis? Bronchiolitis in infant.
Bronchiolitis is most of the time the bronchiolitis because the distal part of the bronchiole result in a dilation of alveoli. You can have hyperresonant. The percussion can be normal or resonant or hyperresonant. And then because of distal part of the bronchiole result in consolidation of the alveoli, you can hurt also bronchi when you auscultate, plus capitation and bronchi. Okay, anything else? Okay, finish. Yeah, okay.